Okay, so we talked about the posterior mediastinum this week, and the way I remembered it, all of the contents in it was thinking dates. So this would be descending aorta, the azygos, thoracic duct, esophagus, and then the SVC. And in the inferior mediastinum, it's below T4 to T5, and it's posterior to the pericardium, which we talked about last week. So let's talk about the parts. So we've got our esophagus, and that's going to be in between the trachea and the thoracic bodies. It's really important to remember what is in front and what's behind, or what's beside. So like, for example, they could ask you a question like, there's a mass or something growing in the esophagus, and they want you to know what's behind it or what's in front of it. So if they said that there's some mass and it's growing anteriorly, you need to know that it could be affecting the trachea. It's innervated by the vagus nerve, which passes behind the lung roots, and it's part of the parasympathetic nervous system. And we're going to talk more about sympathetics and parasympathetics in a few slides. So there's visceral afferents from the sympathetic, which relay pain to the CNS, which is important to remember. So our blood supply, since it's near the aorta, it's going to be part of that, the thoracic aorta, bronchial arteries, the left gastric artery, which is from the celiac trunk, which is our foregut. And I've got a picture. I'm not going to show it to you this week, but it's going to be in my slides for next week, because you guys talk more about foregut, midgut, and hindgut. And so I'm going to try to take all of the nerves and the arteries and the sympathetics and parasympathetics and sort of like mesh it together so it's one big picture. So it'll make more sense next week. So I'm not going to go into a lot of detail about that right now. But the esophagus has some points of narrowing. So the junction of the esophagus and pharynx is a location where it crosses, or where the esophagus is crossed by the arch of the aorta. It presses on that, so that could be a point of narrowing. And where it's compressed by the left main bronchus, and then also at the esophageal hiatus, which is T10. So why that is important is because at those areas, there might be, somebody might swallow something and it gets stuck. And so that's where some piece of food or something might get stuck, is where this is narrowing. Okay, this is a recycled slide, and that's why I put the little recycle symbol. We talked about the azygos system last week, and it's in the part 1 of 4. So you can see in the picture here, let's see. That we've got the azygos that comes down on our right side. And then we've got the accessory hemiazygos, which is draining the upper left portion. And then we've got the hemiazygos draining the bottom of our posterior ribs. And remember that the anterior intercostal veins drain into the musculophrenic or internal thoracic, and then into the subclavian vein to get us to our heart. Okay, the thoracic duct is also in the posterior mediastinum, and this is really important because if you look in this picture, the light green, you can see that it's drained by the thoracic duct, everything below the diaphragm and left of the thorax, head, neck, and left upper limb. But everything else that's in this dark green area is drained by the lymphatic duct. And the location of it is posterior to the thoracic duct, in between the aorta and the azygos. So in lab, don't cut this out. Even though you cut out a lot of lymph and stuff, keep the thoracic duct there. I accidentally cut that out last year, but it was okay. So they love to ask questions about thoracic, or like about the ducts and lymph. Like they'll ask like one question or whatever, and it's just important to get the big picture. And so just know that the thoracic duct drains the body below the diaphragm in the left thorax, head, neck, and left upper limb. Okay, here is, oops, let's try to get rid of this annotation. Okay. So here's our sympathetics and parasympathetics. So I try to break it up into if it's preganglionic or postganglionic. And I drew this little picture to help show what it looks like. So in our sympathetic system, the preganglionic length is short, where the postganglionic length is really long. So I sort of think of it as like when you're in lab and you're looking at the body, coming straight off of those vertebrae, it's going to be really short, then it'll synapse, and then you've got really long nerves that go out to our body. However, in our parasympathetic, the preganglionic length is going to be super long, and then it'll synapse, and then the postganglionic will be really short. So the top two are like preganglionic fibers. It gets more important when you guys take pharm, but they're both nicotinic, but then norepinephrine is what is the type of neurotransmitter with the sympathetic system, and then muscarinic is more important for the parasympathetic. So our locations, this is what's more important for anatomy. It's our thoracolumbar, which is T1 to L2. So it's super important that you remember that these vertebrae lengths. And then craniosacral for the parasympathetic. So cranio is going to be the cranial nerves, 3, 7, 9, and 10. And this comes back again in the fourth block. And then the sacral nerves, 2 through 4. So the actions, like you guys have probably heard a million times, are fight or flight. So if I'm like running from a bear, my heart rate's going to go up. My arteries are going to constrict. I wouldn't have less urination, less defecation. I'm not going to digest because I need to be running. I'm not going to have as much saliva. And then mydriasis and meiosis, you're going to talk more about in the fourth block. So then for parasympathetic, I think, it's the rest and digest, but it's also known as SLUD. So salivation, lacrimation, that's like tearing, urination, digestion, and then defecation. Also, there'll be bronchoconstriction, and you're going to have a decreased heart rate and vasodilation. So these are sort of just opposites. So if you know one, you can kind of get the other. Okay, I know sympathetics and parasympathetics can be hard, but it's sort of just baby steps, and you're going to get more and more, you're going to continually be introduced to this, so it'll make more sense along the way. Okay, so you had Dr. Chestnut. Oh, got a message. Okay. Yeah, I think somebody's mic is on, and they're talking. Okay. Okay, so you had Dr. Chestnut. So what I have to say about Dr. Chestnut is that a lot of times I'm not the best at looking at objectives and making sure that, they're correct, or, knowing. I'm not going to necessarily know the objectives, but I know the slides, if that makes sense. But in Dr. Chestnut's case, I would definitely know his objectives, because sometimes they're like questions. Like it'll, like one of his objectives was know the 5 densities. So he could ask you on the exam, like, what is this density? For example. So I just took this straight from his PowerPoint. And that's why there's animation. But we've got air, there's fat, water, bone, and then metal. So as you can see, the bone and metal are going to show up more bright white, where things like air, water is going to show up a darker color, and fat is kind of in between gray. So I would know those. So if he points out something and says, what is this? You'll know that it's air versus bone versus metal, something like that. Okay, I would go through all of his images, because he'll tell you this in class and it's like 100% true. He'll use the same picture that he had in his slide, like on the test. So go through the pictures and know where things are located. So I only picked a few, but of the like harder ones. But just go through all of them. So like I see that this is the ascending aorta, and then we've got the right pulmonary artery. And if you can like look through these and start figuring out and seeing the picture, like the CTs and like how they go through as the patient moves through the CT scanner, and you'll see how things move and where things are located. Like our descending aorta is over here by our vertebral bodies. Just keep practicing. You can go online and there's like, you can just go through a normal CT and just follow it, and they'll point out things to you. You can just Google it and you can find it usually. But just the more you practice, the better that you get with imaging. And it's sort of like histology. You know, you have to see the picture a million times and then you're like, oh, I can kind of recognize that. It's sort of the same with x-rays. Right here, this is of our heart, of course, and we've got our LAD, and that's the most common one. So if I were writing a question, I would probably like show this. If I showed this picture, that's what I would label, would be the LAD. All this stuff is not important. And then here's the right coronary artery and posterior descending artery. So just go through his pictures. Okay, abdomen. And this was with Dr. Dudzik. So we've got layers of our superficial fascia, and going from most superficial to deep, we've got our Camper's fascia and then our Scarpa's fascia. And so our Camper's fascia is made out of adipose tissue, where Scarpa's is made out of the membranous connective tissue. And remember, you camp out and scarp in. That's her little saying. So this goes to the superficial fascia of the thigh, the Camper's fascia, and the Scarpa's fascia joins with the fascia lata of the thigh. In males, both of these become the superficial fascia of the penis and the dartos fascia in the scrotum. And we'll talk more about that development as well. And deep to these muscles, here is our transversalis fascia. And then there can be this potential space between Scarpa and the deep fascia where fluid can accumulate. Okay, so our abdominal wall. So just like we had talked about in the thorax, these are the same orientation of fibers. So the external oblique are those hands in pockets. Internal obliques are the opposite. And then transverse abdominis, like transverse just really means like parallel with the ground, that just goes across. So those fibers are horizontal. Above the arcuate line, it's deep to the rectus, and you can see this right here. So here is our transverse abdominis, and you can see how it's deep. And then after The arcuate line, which is like around right here, like under our belly button, it's going to be superficial to rectus. So you can see how that goes above this. And that's a really important concept to know. So above that line, transverse is deep, and then below the line, it's superficial. And then rectus abdominis is like our abdominal muscles, our abs. So, it does flexion of the abdomen. And all of these abdominal wall muscles increase intra-abdominal pressure. Okay, innervation and blood supply. So where it's innervated by the ventral rami, and that passes between the transverse abdominis and the internal oblique muscles. And remember, internal oblique and then transverse abdominis. It pierces the rectus sheath to innervate rectus abdominis. And you can see that in this picture, how it goes around and pierces to get rectus abdominis. The blood supply, the upper part, internal thoracic, sends off a branch called superior epigastric artery. And just to review, last week we had talked about internal thoracic gave off the first 6 intercostal arteries. And then it also gave off musculophrenic, and then the other 6 came off of that. And then we had superior epigastric. So in our external iliac artery, a branch from that gives off inferior epigastric. So now we've got our superior and inferior. They're going to meet up. Then the obliques are from musculophrenic, again, which was from internal thoracic, posterior intercostals, and this subcostal artery. Okay, inguinal canal. This can be a little bit daunting. I know there was like a ton of slides on this, but I tried to condense it. So the inguinal canal borders the anterior part, and I tried to color code it the same. That's going to be the inguinal ligament, which I'm sure you found in lab. The floor is also the inguinal ligament because it sort of wraps around. And then the posterior wall is going to be the transversalis fascia and then the conjoint tendon. So that conjoint tendon is made up of, and you can see it in this picture, it's made up of transverse abdominis and the internal oblique. So they come together and sort of form that tendon. And then the roof is going to be the arching fibers of the internal oblique and transverse abdominis muscle. So it's a really tight little area, and some of it sort of overlaps, but these are the borders. So I would always remember if they give you borders for anything, I would know what the borders are and what are the contents. And we're going to talk about these contents. Okay, so we've got 2 rings. We've got a deep ring and we have a superficial ring. So the spermatic cord is going to enter the deep ring and it's going to come out the superficial ring. And we've talked about these muscles, and it's important to know their names change as they become in this inguinal, as they pass through the inguinal rings. So the external oblique muscle becomes the external spermatic fascia, which is easy. They're both external. But then we have to think, okay, another layer back is going to be the internal oblique muscle. But that's not going to be the internal spermatic fascia. So that seems confusing, so they could ask you a question because they want to make sure that you know the difference. So the internal oblique becomes the cremaster fascia and muscle. And then the transverse abdominis, we remember that's the innermost abdominal muscle. That one's going to become the internal spermatic fascia. The contents of the spermatic cord are the ductus deferens, testicular artery, papiniform plexus, which is veins, the genitofemoral nerve, the genital branch, sympathetic nerve fibers, and the visceral afferents, and then the lymphatics. And you get all of this again sort of highlighted again in third block, but it's really important to know this now, especially when it comes to hernias. And so here's some hernias. So there's an indirect and a direct hernia. So the way I remember indirect hernia is that it's in both rings. It goes through the deep and the superficial. So here's this one. So here it is going through our deep inguinal ring, and then it passes through and goes to the superficial inguinal ring. Direct, however, it's going more medial, and it's medial to the inferior epigastric arteries, and it's going directly down. So it misses that deep ring and is able to go through the superficial ring. So indirect in both rings. Okay, the lumbar plexus. So she started going through each of these branches, but this is sort of like all of them together so that you can see it all on one page. So the way I remembered this is in Ireland, good lads feel okay. And this is to remember it with the nerve roots. Now, right now, I didn't see on the slides that you had to know the nerve roots. I think that you have to know those later. It may be in like next week's slides, but they're here for you. But the way I remembered them was L1, 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 L2, L2, L3, L2, L3, L4, L2, L3, L4. And so just by like saying that multiple times, I was able to like remember it. And then if you know the mnemonic, you can line these nerves up. So iliohypogastric. And the first two, I know they both start with the I, but the H comes before I in the alphabet. So you can just like put them in alphabetical order. So iliohypogastric, ilioinguinal, genitofemoral, lat fem Q or lateral femoral cutaneous, femoral, and obturator. And then this picture, you can find each of these and then go to lab, find these. Sometimes they're a little bit hard to find when you get like to that part of the dissection. Just be able to like find these because they're sort of hard. Like when you get to the practical or whatever, you know, grab one of the scholars or grab a professor and like go through them, because if they tag one of these, sometimes it's sort of difficult to know which one is which. And just know where it's going to. So like, for example, the lat fem Q, the lateral cutaneous is going to come out and go to the lateral thigh. And so there'll be a portion that gets the sensation to our lateral thigh. So if you see it's going, okay, this one's going more laterally, then I know that, okay, that one might be that one. Or the obturator, it's going to go through the obturator foramen. So be able to like know where these are going. Okay, the inguinal development. So the gonads are going to develop in the posterior abdominal wall. And then this gubernaculum, it pulls the inferior pole of the gonad through the abdominal wall to this labioscrotal swelling. The testes are going to descend along the gubernaculum through the inguinal canal, becoming the spermatic cord. The process vaginalis closes off to the tunica vaginalis surrounding the testes in males. But in females, the ovaries stop descent in the pelvis because they're not going to, come out. They're going to stay in the pelvis, and the gubernaculum remnants. And this becomes the round ligament of the uterus. Okay. I included this slide in here just for lab. It's really not too important as far as like lecture wise, but I would know that the median fold is called the urachus, and you're going to get that in embryology when you guys get to the abdomen part. But I would know that the like median fold is the urachus. It's probably important for lecture as well, but knowing where these are in lab and like being able to find them is really important. So you have median fold in the middle, then the next one is the medial fold made up of the umbilical arteries, and then the lateral fold. Okay. So the peritoneum. So we've got a greater sac and a lesser sac. And so here's this lesser sac. It's also called the omental bursa, and it's behind the stomach. And then on the outside is the greater omentum, so it's that fatty apron so that you lift up to be able to see the inside of all of the guts. So both of these are connected through the epiploic foramen, or also like omental foramen. So that is the entering, and right here is the epiploic foramen, and that's the entrance to the lesser sac. Okay, the male and female part is not as important to know. Okay, the portal triad. You guys will talk more about the triad when you talk about the liver, but I just wanted to point out this is another view of it, which is connected to the stomach by the lesser omentum. And so, okay. So you have to know if it's intraperitoneal or retroperitoneal. So the retroperitoneal are going to be the things that are like stuck on the back. And then intraperitoneal will be something that's like, I sort of think of it more as like an island organ, or, that's like off by itself, where these retroperitoneals, they're just, they're far back. The way of remembering these retroperitoneal organs is sad pucker. And so suprarenal, aorta plus the IVC, duodenum, the second through the fourth portion, pancreas, ureters, colon, kidneys, esophagus, and rectum. And so due to these spaces and pericolic gutters, infection can spread really quickly. So if there's an infection in one of these retroperitoneal organs, let's say the colon, well, it can affect the kidneys. So that's why it's important to know what all of these structures are. Okay, so now we're to embryo. And so I'm going to give you really highlights on the heart embryo. But what I would say as far as embryo, I know that you have a lot this block. I would look for, let's see, I took some of the things straight off. Okay, this is straight off his slide. So when he bolds something, it's pretty important, and I would know it. And then also with the heart, since there's so many clinical things like malformations, I know that they've got a lot of questions in Gray's, but then also in BRS, and don't do the not the anatomy BRS, but the embryo BRS, and then look at the questions involving cardio or the heart. And I found that those questions were really similar to what I saw on the test, and it sort of gave me a way of knowing how that they could possibly ask a question about some of these malformations. But it's also important to know besides the malformations, some of these foldings and different things in the development in general. So the folding of the heart tube. Second, I got a question, I think. Yes, BRS embryo. It's I can show you guys it if you need me to, after this. But it's BRS embryology. It's not BRS anatomy. Okay. Okay, so the heart fold, he loves folding. If there's something about folding or turning, it's really important in embryo. So the heart tube folds and loops to develop this spatial relationship for the future heart chambers. And so in the beginning, we've got this like strange looking structure where it's just, we've got like a primitive ventricle and primitive atrium. Now, if you look at it, you're like, what? This is upside down. Well, it sort of is. So that's why there's like, it's important that there's the foldings and loops because, well, first off, we've got 2 atria, but like, why is it down here? So these foldings like get us to the right location. Okay. There's 2 types of veins. We've got our vitelline veins, which drain the primitive gut tube, and then our umbilical veins give us our oxygen-rich blood from the trophoblast in the developing placenta. Okay, so our sinuses. If you've taken a look at the heart in lab, you can see that big sinus. And so the development of the sinus venosus comes from the left horn as it decreases in size and it becomes that coronary sinus that we see in lab. The right horn enlarges and it forms the SVC and IVC. So I would know that the left horn is coronary sinus and then the right horn becomes SVC, IVC. Okay, partitioning of the atrium. So there's a foramen secundum and primum. And the foramen secundum forms as the premium closes. So I thought this diagram was the best. It sort of like made more sense to me. The secundum grows inferiorly, but there's a place that's open, which is the foramen ovale, so that we can get that blood shunted from the right to the left. So we want, because of the pressure hasn't built up, you know, we're still getting oxygenated blood from mom. There's no lungs in the baby that can be able to, you know, like breathe. So all the oxygenation comes from mom. So that's why we've got that foramen ovale. And then the septum premium is really thin and it is a one-way valve. So when the baby takes their first breath, there's a pressure change. And so there's going to be higher pressure in the left atrium than the right atrium, and it's going to push this septum premium closed. And so we can have some malformations if this doesn't all the way close or if there's a hole or something in it. Okay, partitioning of the AV canal. So there's these cushions, and right here, here's endocardial cushions, and they're going to grow towards one another to form the left and right AV canal. So these cushions are pretty important in forming the AV. Okay, the outflow tract, which is the aorta and pulmonary trunk, the bulbar and truncal ridges fuse to form that aorticopulmonary septum. And you can see here's the septum right here. The separation of the ventricles, it's in the 4th week, and there's a muscular interventricular septum which separates the ventricles. The interventricular foramen temporarily exists here. Okay, this picture, really odd. I'll see if I can find it, but it was really helpful, I thought. It takes you through how to draw this and teaches you about embryology of the heart. So I'll go through this. So we've got, so these monkeys represent primitive. And then our trunctus arteriosus is the ascending aorta. And our sinus Venosus is the coronary sinus, and then the bulbous, it's a bulb, light bulb, cordis is smooth. And so, like, if you can go through and draw these, it can help you, like, know where each of these are located. So the sinus venous, so it's like a venom sign, it sort of sounds similar. It's going to be in the right atrium and the left ventricle. And then there's going to be primitive trabeculated ventricles in all four of these. The smooth bulbous cordis is going to be in the both of the ventricles. The cardinal vein, so it's a little cardinal bird, is going to be sitting right here on our coronary vein. And so, I don't know. I'll try to find the video, though. It was pretty helpful. Okay, malformations. I tried to put just the most common, or like the most important ones that I could find on here, and like the most important things about each one. So we've got an atrial septal malformation, and I just like try to think about, okay, like it's the atrium, septal, okay, it's going to be between the two atria. There's gonna have to be like some problem like with blood between there. So there's going to be a mixing of oxygenated, deoxygenated blood. And so that's where it is. So it's going to be a probe patent foramen ovale, which it's like small enough to allow a probe to penetrate. But since it's so tiny, it doesn't allow a lot of blood to mix in between. So that's not too much of a problem. A septum primum malformation, it's going to leave a bigger size hole. So there's going to be more oxygenated versus non-oxygenated mixing of blood. Ventricular septal malformations. So we talked about the muscular ventricle, but there's also this membranous. And so the membranous is the one to remember, is this malformation is a failure of the fusion of the interventricular septum with the endocardial cushions. And so the muscular one is not really a problem, but this membranous one is a problem. So if there's no fusion of these cushions, then we're not going to be able to have a ventricular septum and have blood mixing. Persistent trunctus arteriosus. The trunctus is supposed to separate at the beginning when we create our outflow tract, but in this case, it doesn't separate. And so there's going to be a common opening of the aorta and pulmonary trunk, and because it was never like two separate vessels, and they just become one. So there's no separation of blood flow between the aorta and the pulmonary trunk. Okay, so here's some more. Unequal division of the trunctus. So the pulmonary trunk is fed by the ductus arteriosus. And so the right ventricular blood gets into the aorta. Tetralogy of Fallot, that one is like by far the most important. And it's got so many things going on here. So we've got pulmonary stenosis, and that's what this picture is. And so here's the pulmonary stenosis right here. There's going to be a ventricular septal malformation. So right there's our septum malformation. We're going to have an overriding aorta. So here it is, overriding. And then we're going to have hypertrophy of the right ventricle. So our right ventricle is going to be way too big, because instead of having like the left ventricle doing a lot of work, and usually we talk about in a normal heart, the left ventricle is going to have a thicker wall. But right here, since the right ventricle is trying to make things work, it's going to end up becoming like bigger, which in the heart is not a good thing. And then we have transposition of the great vessels. So it's like they flip-flop, and so the right ventricle is going to pump into the aorta, and the left ventricle is going to pump into the pulmonary trunk. So there's not going to be any oxygen transfer to the systemic circulation. There'll be a patent ductus arteriosus. And all of this is going to contribute to the mixing of blood. And then the last one is going to be the coarctation of the aorta, and it's going to be an explicable narrowing of the aorta near that ductus arteriosus. So the blood pressure in the upper extremity, so like our arms, are going to be increased, where blood pressure in the lower extremities are going to be minimal. So for example, if it asks a question about that they took a patient's blood pressure, and let's say it's 170 over 100, but it was 120 over 80 when they took the blood pressure in their ankle, that would be the coarctation of the aorta. So I would have some practice questions, but we also had an exam this morning, so I sort of ran out of a little time. But what I would do, so for Dr. Hermes' lectures, I think you measure like the best questions to review for her lectures. I would use like the BRS embryo for these embryo lectures, and then I would probably go over like Gray's and probably UMich too for like the rest of them as far as practice questions. And then like I don't know how lab and everything went for you guys, but I would definitely like try to get in the lab. Like, don't wait to the last minute. Make sure that you have like plenty of time. And this stuff, like all of the gut stuff, gets super complicated. So just make sure that you get into lab in like plenty of time and go over it with like professors or the scholars or anything. And just make sure you know it, and like make sure that you know it in different orientations, because like as you now know after like coming out of one practical, they can like put stuff in weird orientations, and you have to be able to like not be able to touch it first off, and then second off orient yourself so that you can figure out where things are going and where they come from. So do you have any questions?